Okay, well, it's 12:05, so let's get started. Welcome, everyone. This is once again the UCCS Speaker Series. I'm Richard Kravitz, Director of UC Center Sacramento, and it's a pleasure to welcome you once again. As you know, the purpose of this series is to make policy-relevant evidence and science produced on the 10 campuses of the University of California accessible to policymakers and to the community. And through our speaker series, special panels and workshops, policy briefs, and various other means, UCCS attempts to build bridges between UC students, UC researchers, and California state policymakers. And of course, you can find out more about us at uccs.ucdavis.edu. So today we continue with our theme of using big data to inform public policy, focusing specifically on drug and suicide deaths in California. These so-called deaths of despair were rising before the COVID-19 pandemic, and they will, if anything, be a bigger problem going forward as vast swaths of the population cope with social isolation and economic disruption. To address this topic, I'm very pleased to introduce Sidra Goldman-Mellor, Assistant Professor of Public Health at UC Merced. Dr. Goldman-Mellor is an epidemiologist with a focus on mental health and particularly the determinants of suicidal behavior over the life course, links between violence and mental health conditions, and effects of mental health on physical health and economic outcomes. She has an MPH and a PhD from the UC Berkeley School of Public Health. She has funding from the National Institute of Mental Health, as well as the UC Firearms Violence Research Center, and is author or co-author of nearly 40 journal articles, including 12 appearing in just the last year and a half. So she's been extremely busy. So here to help us understand deaths of despair and maybe to offer some suggestions on what to do about the problem, I'm pleased to turn things over to Dr. Goldman-Mellor.
Thank you. All right. Okay, thank you so much for that introduction. Thank you again to Dr. Kravitz and UC Sacramento for the opportunity to be here. I'm sorry that it can't be in person, but I look forward to hopefully answering your questions and chatting with you all a little bit after the presentation is over. Okay, so I don't want to waste anybody's time, so I am going to launch right in. And I know that this is sort of a heavy topic to be talking about today, but I do think it's a very important topic and look forward to sharing some of my research with you. Oh, no, it's not. There we go. Okay, so let's see. So as Dr. Kravitz mentioned, suicide rates in the US have been increasing quite steadily over the last 18 or so years. So these are data from the Centers for Disease Control and Prevention showing that the suicide rate in the US has increased about 33% over the last 18 years. This overall kind of rate or pattern kind of masks what's happening in subgroups. So you can see from this graph that males are pretty much always at higher risk for suicide than females. But interestingly, the suicide rate among females has increased more over the last 18 years than the corresponding rate among males. So the suicide rate is a major public health challenge. It's also kind of what's happening at the same time is that the death rate from drug overdoses has also increased, and frankly has probably gotten a lot more attention in the media. This is, of course, largely, although not entirely, due to the opioid epidemic. So these are sort of corresponding data from the CDC showing that the drug overdose death rate has increased a whopping 255% over the last 18 years. And it's gone up with sort of similar amounts in males and females, although females actually it's increased a little bit more. I do want to note one thing here is that some of the drug deaths that are shown in this graph are in fact suicides or deaths that have been ruled as suicides. They were caused by a drug overdose, but they have been ruled as intentional. So the graphs actually show like slightly overlapping data, but it's not immediately obvious that that's true. So at this point, as you can see, if you focus on the right-hand column over here, so these are data showing the 10 leading causes of death in the US as of 2018. And what you can see here is that, so down in the bottom in the green box, suicide is now the 10th leading cause of death overall in the United States, which is really sort of unprecedented. In the blue box, it's labeled unintentional injuries, so that's the 3rd leading cause of death in the US, but actually the majority of those deaths are in fact unintentional or accidental drug overdoses. Not all of them, because that category also includes motor vehicle accidents and other things. But you can get a sense that the drug overdose deaths and suicide are leading, if not the leading causes of death overall, and particularly in younger age groups in the United States. So this is a really pretty profound public health challenge. In California, we've seen sort of similar trends, but at kind of a lower level. So California has had lower suicide rates than most of the, than kind of compared to the average of the US. Nevertheless, over the last sort of 18 to 20 years, suicide rates in California have increased 13%. We've also seen in our state a 48% increase in drug death rates. Again, some of these drug deaths are suicides, so these are slightly overlapping. So California hasn't been hit as hard by the opioid epidemic as other states have. Nevertheless, we are seeing big increases in drug overdose deaths and in suicides. So this is kind of good news and bad news for California. So the good news is that our state does have lower than average drug overdose death and suicide rates. On the bad news side, both of those rates are still rising. And as Dr. Kravitz said, I mean, nobody knows the future, but they may continue to go up in the future. So this is a big public health challenge, or in fact, sort of two different but somewhat overlapping challenges. So like any public health challenge, normally, so typically public health people think about addressing these kinds of challenges with multifaceted approaches. Like there is no silver bullet here. There is no one thing that's going to solve these problems. Instead, we think about tackling these challenges at kind of 3 different levels. What those levels look like differ a little bit depending on what health outcome or health problem you're talking about, but it's a good sort of framework to think about these things. So primary prevention, so down at the bottom of the triangle, is preventing the health problem from happening at all. Basically, it's preventing people from developing the health problem in the first place. So this might be measures that we can take to help the entire population sort of avoid development of suicidal distress, addiction problems, etc. Stop it before it gets started. Secondary prevention, in the second tier, is uncovering the problems among people who might not sort of either know that they have a problem or who they haven't come to the attention of a healthcare provider. They have kind of low-level symptoms, if you will, or a low-level kind of problem, but that those problems, such as experiencing depression, thoughts of suicide, the beginnings of drug addiction, those could present big problems in the future. And so we're trying to uncover those problems and get help for those individuals before the problem gets worse. With tertiary prevention, the problem has emerged kind of full blown, and what we're trying to do at that point is get the people who are suffering from that health problem into care, into treatment, and prevent the problem from getting much worse and potentially leading to their death. So that would be sort of treating people who have maybe attempted suicide or overdosed on drugs, getting them into treatment to prevent them from dying in the future. So the work that I do is largely, or at least the work that I'm going to talk about today, is largely focused on these 2 levels of prevention. And part of the reason I am interested in primary prevention, but a lot of the work that I do these days is focusing on healthcare context as a site for secondary and tertiary prevention as it relates to suicidal behavior and drug overdose. And the reason that I focus on healthcare settings is because so healthcare settings, I mean things like your doctor's office and emergency departments and healthcare clinics and even the hospital as well. So those healthcare settings are potentially promising, but often sort of underutilized contexts for implementing secondary and tertiary prevention efforts. And this, with respect to suicide and drug addiction and overdose, the reason that I say that healthcare settings are sort of a promising setting for thinking about prevention is a large amount of research. So I've noted a couple of papers here, but there's actually a pretty big body of research showing that suicide decedents, so people who have died from suicide or from a drug overdose, most of them are engaged in the healthcare system. Most of them, more than 80% of them, have had at least one healthcare contact in the year prior to death, whether that's in their primary care office, their emergency department, etc. So that research is sort of looking at the people who have died and looking backwards in time, seeing like where have they gone to the emergency department, or when have they seen the doctor, what were they presenting with when they actually went to the doctor. So that's quite useful research to get a sense of, okay, like where were they, prior to their death. But what that doesn't tell us is, that's only focusing on the people who have died. It tells us much less about all the people who are coming into the healthcare system, but maybe are not dying by suicide. Most of them are not dying by suicide or drug overdose. And so what there has really been missing in the research is follow-up data on healthcare patients. And what I mean by that is looking at a population of patients who are coming into the healthcare system. I particularly focus on emergency departments, but people who are coming into the emergency department and then following them up over time to understand what proportion of them are dying of suicide or drug overdose. Are there subgroups in there who are at particularly high risk for suicide or drug overdose? And using that information to inform treatments, prevention programs, policies, etc. Okay, so why is that helpful? Like, why could it be important to have this sort of follow-up data on patients? So for a few different reasons, actually. So if we have a better understanding of mortality outcomes, suicide, drug overdose mortality, among these patients who are coming into the healthcare system, that would help for a variety of different reasons. For one thing, perhaps most importantly, it would help clinicians make treatment decisions. Clinicians tend, not to know, or they tend to be guessing sometimes. It's their best guess, but without sort of population-wide information about who is most at risk of dying of suicide, they are hampered a little bit in making the best kinds of treatment decisions. Risk stratification efforts are another thing that could benefit from this. So what do I mean by that? This is a sort of a clinical term, but what it means is that faced with kind of a given patient, so a patient who has come into the emergency department because they're thinking about suicide, they've maybe told a friend of theirs that they're considering suicide, and the friend brings them to the emergency department. The clinician is forced to make a decision about, is this person at high enough risk of suicide that they need to be hospitalized immediately, that they need to be got in a hospital, an inpatient bed, and have lots of intensive resources devoted to them. Whereas, faced with another patient, maybe they might be at lower risk of suicide. So the risk stratification allows clinicians and other providers to make sort of triage decisions about who should be given scarce healthcare resources. But if we don't know who is most at risk of dying by suicide or drug overdose, it's very hard to make those kinds of decisions. The last thing that, or one of the last things that understanding mortality outcomes can help us with is by informing and crucially generating demand for healthcare quality improvement efforts. So I want to note here that longitudinal tracking of mortality is actually totally routine in many parts of healthcare. So we do it constantly for cancer patients. It's a standardized part of the care is that we track for cancer patients what their outcomes are, including whether they are dying. But this kind of tracking is basically never done for patients who are presenting with mental or behavioral health issues. It's just not a part of the standardized form of care. Part of the reason for that is that suicide and drug overdose, although they're more common than most people think they are comparatively rare. And so what that means from kind of a research perspective is that you need massive amounts of data in order to be able to kind of detect these patterns and these trends with any certainty. So that is where big linked data can come into play. And California is sort of particularly well positioned to contribute in this kind of sphere. So since the 1990s, really, the California Office of Statewide Health Planning and Development, or OSHPD as it is typically referred to, has made available for researchers data on all emergency department patients and all hospital patients across the state in any state licensed hospital. And crucially, one of the things that they make available to researchers is patient unique identifiers. So this is a unique ID that is specific to a patient. And what it allows a researcher like me to do anonymously, I don't know who anybody is in the patient data set, but I can tell that it's the same person over time. And what that allows me to do is tell that this patient, maybe they came in for a visit in San Joaquin County in 2010. I can then track them over time as they're going in and out of the hospital, potentially in other places around the state. OSHPD has also, really crucially, had a partnership with the Vital Statistics Office of the state, which allows researchers like me to track whether an individual patient has died. So we can tell whether a patient who has come into the emergency department in 2010, if they die of any cause over the next few years, we can link that death record to their patient, their healthcare record, to understand, what they died of and when it happened, and circumstances around the patient visit and then the death. So what that allows me to do is calculate mortality rates among these big groups, all the people who are coming into the emergency department seeking care for different things. So there's lots of things that I can do with those data, and other researchers like me can do with those data. Typically, sort of my basic approach to this has been to look at these huge data sets, 55 million records over several years, is to kind of sift through the data and identify groups of patients that I might be interested in, such as those coming in because they're suffering from a psychotic episode or depression and so on. So I can kind of sift through, take out those patients and then calculate their mortality rates. And through some kind of statistical wizardry, the other thing that we can do is compare the death rates among those patients to the death rates in the entire California population, or really what the death rate would be in the entire California population if the entire California population sort of looked like those emergency department patients. And by looked like, I mean if they had the same age, sex, and race sort of distribution that the patients had. And so what this is basically, I'm not going to go into a lot of methodological details here, but basically what this is doing is saying, allowing you to make apples to apples comparisons about, what's the death rate among the emergency department patients, and how does that compare to what it should look like if they were basically just like the rest of the California population. So I'm going to give sort of some examples of what this looks like. I'll talk sort of quickly through 3 different projects. And the first of those projects is looking at mortality outcomes among ED patients, emergency department patients, who are presenting with suicidal behavior. Okay, so to do this, I started with 2 different groups of patients presenting with suicidal behavior. The first of those groups are called the deliberate self-harm. So these are people who have shown up to the ED and because they've either made a suicide attempt or they have deliberately harmed themselves, potentially without the intent to die. So this sometimes involves like cutting behavior, that kind of thing. So these are called the self-harm patients. So I pulled out all of the self-harm patients who showed up to the ED but sometime between 2009 and 2011, and they were one group. Then another group that I pulled out were people who showed up to the ED because they were thinking about suicide. They were thinking about attempting it, but they hadn't actually injured themselves yet. So they didn't have a self-harm kind of diagnosis. This is all based on medical diagnoses. So that was the second group. The third group that I want to compare them to was what I called reference patients. So this is a random sample of all other patients in the entire study period. So they could have come in with a broken leg, the flu, stomachache, asthma, anything else, just a totally random sample. And I followed all of these groups of individuals for up to a year to calculate their death rates. So let me orient you to what these results look like. So shown on the in the black bar on the left. So this is the suicide rate in the California population, if that California population had the same age, race, and sex kind of pattern or distribution as the emergency department patients. So it's actually quite similar to kind of what the typical or what the actual suicide rate is in the matching California population. So you can see, so the little numbers above the bars, that means that in this California population, the suicide rate was about 12 per 100,000 people. So out of every 100,000 people in California, 12 of them would die by suicide during this study period. So first I'll show you, so on the right hand is this gray bar is this reference patient sample, right? So this is the random sample of all other ED patients. And you'll note that their suicide rate was about twice as high as the underlying California population. So already like we're starting to see like, you know, this is just a random sample of emergency department patients, but their rate is twice as high, their suicide rate is twice as high. This is the same information, exact same information, but I've sort of stretched out the scale, because when we then look at the suicidal ideation patients, right, so these are the people who have come in because they're thinking about suicide but have not injured themselves, their suicide rate was 26 times higher than that of the matching California population. Then when we look at this last group, so the self-harm patients, their rate of suicide was 56 times higher than the comparison group, the matching California population. So their suicide rate was almost 700 per 100,000, which is just an astronomically high suicide rate. It's just incredibly high. And again, you know, so they came in because they had attempted suicide, but it was, or had harmed themselves. It wasn't fatal, so they, you know, got discharged eventually from the hospital. So this is their suicide rate in the year after they were discharged. So then I didn't stop by looking just at their suicide rate. So my collaborators and I on this project wanted to look at the mortality from other causes as well. And what we see here is that the self-harm patients and the suicidal ideation patients, that's what I'm focusing on here, they're at risk not just for suicide, but also from other causes of death. So their rate of death from accidents was between 13 and 31 times higher than the underlying population. Their rates of homicide were 3 times higher. And their rates of death from natural causes were 3 to 4 times higher. So in relative terms, not quite as high, but the absolute number of deaths due to natural causes was actually much higher than for suicide or any of the other causes of death. We also saw that there were subgroups who were at even higher suicide risk. Older men, so this is sort of looking within each of the patient groups. So we saw that older men were at much higher suicide risk, non-Hispanic white patients, privately insured patients, which was quite interesting, and then patients who were presenting and had more severe psychiatric diagnoses that were kind of recognized by a clinician. So these are kind of subgroups that we need to be paying more attention to. So just to summarize this, so clearly what this is showing, I mean, it's kind of hard to believe that we didn't know this information before, but we didn't. What we see is that the ED patients presenting with suicidal behavior are at really, really high risk for suicide, especially if they've actually injured themselves rather than just sort of thinking about suicide. And then there are those subgroups at higher risk. So the older white males in particular are at very high risk for suicide. But strikingly, suicide isn't the only cause of death that they're at risk for. Perhaps most pertinently, even the emergency department patients who aren't showing up with any suicidal behavior whatsoever, even they have elevated risk for suicide. Okay, so I'll move on to the second project. So this is looking at mortality outcomes among patients who are presenting with a non-fatal drug overdose. So they've overdosed, but they survived that drug overdose. And for this project, I focused on these are accidental overdoses, right? Not self-inflicted. They weren't trying to harm themselves. It was accidental overdoses. So we focused on 2 different groups of patients for this. So these are opioid overdose patients was the first group. with the opioid epidemic is forefront in everybody's mind, and they're a population of huge concern. So these patients, they could have overdosed on either prescription or illicit opioids. We don't actually know a lot of detail about what it was that they overdosed on, other than that it was an opioid. And then the second group we looked at was sedative and hypnotic drug overdose patients. People tend to be less familiar with these kinds of drugs as an overdose issue. So these are drugs, prescription drugs generally, like Ambien, so sleep aids, and then anti-anxiety medications like Valium and Xanax. Even though they're kind of less recognized, they are actually a very large portion of all non-fatal overdoses in the United States. So we pulled out these two groups of patients and looked at their rates of death over the next year. So we looked again first at their suicide rates, because one of the things I'm very interested in is this relationship between drug addiction and suicide risk. So the opioid patients, what we found is that their suicide risk or suicide rates were about 18 times higher than the underlying matched California population. The sedative and hypnotic patients, their suicide rate was about 9 times higher than the matched California population. So again, we're seeing these like really striking increases in suicide rates in these patients. Then we looked at their accidental drug overdose mortality rates. And here it was really pretty staggering. So the opioid patients, their rate of drug overdose, not necessarily opioid drug overdose, just any drug overdose in the next year, was more than 100 times higher than the underlying California populations. Just kind of a staggering increase in risk. For the sedative and hypnotic patients, they also had a dramatically increased risk, but at kind of sort of a lower amount. So their risk was about 24 times higher than the underlying California population. Similarly to what we saw with the suicidal patients, these drug overdose patients also were dying of other causes as well, like not just suicide, not just drug overdose. Their rates of death from natural causes, so these are things like heart attacks, cancer, respiratory disease, anything. Their rates of natural cause death were also exceedingly high. So to summarize this project, clearly, so the opioid and sedative hypnotic drug overdose patients, again, they're showing up to the EDs, they might be getting treatment there, but they are still at incredibly high risk of mortality in the year after that ED presentation. But perhaps sort of even more strikingly than in the suicidal patients, these drug overdose patients, their excess mortality was highest in relative terms for drug overdose, but it was by far the highest in absolute terms for natural causes. And that was particularly true of the sedative and hypnotic overdose patients. And this was really kind of new information, because in previous studies that have tried to estimate drug or death rates among drug overdose patients, they didn't even really look at natural cause deaths. It's mostly researchers have focused on their drug overdose deaths, and that is missing this sort of huge chunk, this huge burden of mortality in these patients. So the last project that I'll talk about is actually, so this is not, this population is not patients, so these are women who are having a baby. So this is a slightly different kind of project. And this work is done in very close collaboration with a colleague of mine at Michigan State University named Claire Margerson, who is a maternal and child health epidemiologist. So this project was motivated because the US has one of the highest postpartum or sort of pregnancy-associated death rates in the developed world. And there was kind of increasing research suggesting that deaths due to drugs and suicide may be accounting for a largish or growing portion of these pregnancy-associated deaths. So these are deaths that occur either during pregnancy or in the 1-year postpartum period. But it really had not received a lot of attention, and we thought that that was kind of an oversight, a gap in the research literature. We knew from other work that opioid use during pregnancy had increased quite a bit over the last kind of 5 to 10 years. We also know just from death statistics that opioid overdose and suicide deaths among reproductive age women had also increased drastically during this time. But there just wasn't a lot of information about what was happening among women who had just given birth and what they were dying of. So what we did for this study was to look at drug-related deaths and suicide in the year after delivery among women who had come to the hospital anywhere in California to deliver a baby in 2010 to 2012. And we also looked at kind of variation in these rates by sociodemographic characteristics. And the last thing that we did is look at among the women who died, we wanted to understand their patterns or incidents of emergency department use, hospital use between their the delivery of their baby and their death, to understand whether those healthcare encounters could potentially be an opportunity to identify high-risk women. So it's the same general design. So what we looked at was just over 1 million hospital records for women's index delivery, so infant deliveries in 2010 through 2012. And we linked those data using the linkage that OSHPD and Vital Statistics provide to the death records in the state and to the women's subsequent emergency department and hospital visits. And what we found when we looked at their 12-month postpartum mortality rates, so these on the bottom, so the x-axis here alongside are arrayed the different causes of postpartum mortality. So you can see that obstetric causes of death were the leading cause of death among these mothers. There were 300 who died altogether during this time period. But I've highlighted the ones that we're interested in. So drug-related deaths were the second leading cause of death in these postpartum women. Suicide was the 7th leading cause of death, but it's almost tied with homicide. Together, drug-related deaths and suicide deaths comprised almost 20% of all the deaths in this population of women. And if you add in homicide deaths, then it's more than 20%. We also found that there were some subgroups who were more vulnerable. So we saw that compared especially to Hispanic women, non-Hispanic white women were at much higher risk for dying by drugs or from suicide. So that was a concerning pattern. We also found that women who were insured at the time of the birth under Medicaid or from a sort of a non-private insurance category were at much higher risk of dying by drugs or suicide than compared to women with private insurance. So that was a concerning pattern as well. We then, when we were looking at among the women who died of a drug-related cause or suicide, we found that 3/4 of them, so 74%, made at least one hospital or emergency department visit between the time of their baby's delivery and death. And many, although certainly not all of those visits, were for mental health or sort of drug-related reasons. So that does suggest that those healthcare encounters could be a chance to intervene. So just to summarize this, these drug-related deaths were the second leading cause of mortality among postpartum women in California, and combined with suicide, those deaths accounted for 1 in 5, so almost 20% of postpartum deaths. But again, there were these subgroups at higher risk that perhaps should be targeted for intervention and prevention programs, and that includes women of non-Hispanic white race and those with Medicaid insurance. Another thing that I'll say is that 2 out of 3, so 2/3 of these drug or suicide deaths occurred between 6 and 12 months postpartum, right? So in the second half of the postpartum year. And that's relevant because that's way after the first postpartum visit that a woman makes to her obstetrician, where that might be the only time that she could be screened, if she's getting screened at all for depression or other mental health problems. you know, the problems may not have emerged by then. They seem to be happening later in the postpartum year, when a woman might not be seeking care for herself and might be kind of flying under the radar and not getting the help that she needs. Okay, so I'll just wrap up here with some implications. So this talks about big data and the usefulness of linked big data. I focus particularly on big data that's coming from emergency departments and hospitals. California has an enormous population, so we've got a lot of data to work with here, and these administrative data sets can be enormously useful. And what the findings are suggesting is that these emergency departments could be a really useful setting for identifying and providing follow-up care for people who are at high risk of suicide or drug overdose. But we can't just stop here. We need to be doing ongoing surveillance of these patterns and correlates of suicide mortality, overdose mortality, and other outcomes, with the sort of expectation that, you know, we improve what we track and we improve what we measure. And so if we continue to measure it, we'll be more incentivized to do something about it, to address these challenges. To address suicide and overdose risk, there are some public health implications. It's sort of standard to say now that we should be expanding provision of suicide and overdose prevention measures in the emergency department. We should be universally screening all ED patients for suicidality. That is now a public health, an accepted recommendation in the public health world. But we also, I think one of the most striking things to emerge from this is that we need to develop new interventions to address the broader mortality risk, their broader mortality burden. We can't just focus on their suicide and overdose risk. We need to be paying attention to all aspects of their health, and integrated healthcare models that sort of integrate medical and mental and behavioral healthcare all together in a cohesive way. That could be really key to improving outcomes. For postpartum mothers, the findings show that we need really to be paying more attention to mortality from drugs and suicide and homicide. They just are not getting enough attention. But that also means that we need to be increasing screening and treatment for women who are struggling with depression and suicidality and drug addiction, but at the same time reducing stigma and punitive consequences. Mothers often may not seek help over concerns that that their child would be taken away, or that there would be other sort of legal consequences. So for policy implications, I know this is a policy talk, so I wanted to come up with some kind of coherent policy implications of this work. To me, the most important one is that the state continue to support the OSHPD and vital statistics efforts to conduct these big data linkage. This is just an enormously valuable resource that the state has, and anything the state can do to to further that that effort would be appreciated, and I think have public health benefits. I know that HHS, Health and Human Services, has a record reconciliation project to kind of increase the linkage. That should be supported. The California Policy Lab, which is a UC-based entity, also is kind of helping out with that effort, and provides kind of support services for people using administrative data. So I want to give a shout out to them because they're really doing great work to support this effort. Another implication is that policymakers should potentially support inclusion of suicide and overdose deaths as a healthcare quality benchmark. So there's a variety of ways to do this. This is not an area that I'm expert in, but the HEDIS performance measure, so healthcare effectiveness data and information set, I can talk more about that if someone's interested in. That may be one way to include these things as benchmarks. And lastly, we need to support legislation to increase healthcare access. I know the state is already making efforts to extend Medicaid coverage to women for 1 year postpartum, so that's great. We should push forward with that, and just generally ensure access to affordable mental and behavioral health care for everybody. So I will leave you with this. Mental health is health, and it affects everybody's lives, but it really just doesn't get enough attention and funding in the policy framework. So I'm here to encourage more attention to it. And I will end there, and I look forward to taking your questions.